to be in this event. I'm really very proud that we are showing the quality of interventional endoscopy in Egypt in the whole Arab countries. I'm here in Dar el-Shifa with this great team, and I'm supervised by my dear colleague, Dr. Nada, and rising star. She will present the case, and I will have we'll have some discussion with you. Please, Doctor.
Good morning. Thank you, Dr. Mohamed. It's a great honor to be with you as a second operator now. And now let me present the case. We have 22 years old female patient. She was complaining of abdominal pain since four months and underwent diagnosed as pancreatitis, underwent pancreatectomy and appendicitis.
Appendicitis.
Yes.
Appendicitis, and she had appendectomy.
Appendectomy, and then after the pain was persistent, with persistent vomiting also. So CT with contrast was done for her and revealed duodenal duplication cyst. And so now would you will confirm diagnosis?
Yes. So the duplication cyst is a rare presentation, yet we can see it especially in the young population. It originates from mesenchymal cells. It has it can originate either in the esophagus.
Yes, bigger.
Excuse me?
Dr. Nady, we cannot hear you well.
Yes.
Could you take up your phone?
Do you hear me now?
We have to check the voice. We cannot hear you as well.
Yes.
It's clear now?
Is it clear now?
A little bit.
Okay, maybe we can raise the voice a little bit. I will try to raise my voice. Do you hear me now more clearly?
Dr. Borrano, you need a question or a comment?
Can you increase the EUS?
Yes, bigger.
Yes. So I will start. I started the examination before from the cardia. I checked the body and the tail of the pancreas, and now I'm in the bulb. Maybe if you can see with me, I'm in the bulb of the duodenum, and I will try to go to the site where the CT checked for the duplication cyst. So I'm deep in the second part. I don't know. Do you have the endoscopic view now?
Yes.
Okay.
Yes.
So I'm in the deep second part, and I'm searching for the duplication cyst first by endoscopy. Then I will screen for by endosonography. So as I'm retrieving my echo endoscope, I'm finding an area here on the left side, on the medial part, which looks like a polypoid projection in the lumen of the second part of the duodenum. The red mark is the site of the suction of the echo endoscope for prior examination, but there is marked lymphangiectasia on the surface mucosa. As you can see, I'm trying to show you. Yes, if you can see here, this is the polypoid projection, and it is on the medial side. I tried to do some endoscopic characterization of the pit pattern, but it's rather lymphangiectasia. So there is no adenoma, no signs of mucosal proliferation. So I will try to start my examination. If we can switch to the endosonographic image, I will try to switch to the endosonography and try to demonstrate the characteristics of this lesion. So
the camera needs to change for the EUS.
Okay, can we please switch for EUS?
EUS.
Yes, now we have it. Thank
Okay, so I will increase a little bit the depth to focus on the wall. And here, as you can see, this is a duodenal wall, and I will try to stay focused. We have here a small cystic on the right side, a small cyst that we try to show more clearly by rotating. The role of EUS in cases of EUS, especially the duodenal, mainly is to confirm the diagnosis, meaning that we want to make sure that is really cyst, not a tumor, and the criteria of the cyst and the layers of origin. So I'm trying to make sure that it is, if it shares, yes.
Dr. Mohamed, can you explain more the criteria of duplication cyst, duodenal cyst? How can we diagnose it? There's some criteria for this?
Yes, the duplication cyst arises usually from the eccentric part of the duodenal wall. Usually it shares the muscularis propria with the duodenal wall. So we want to have 3 layers, but as the cyst is collapsed, the cyst measured at about 2 centimeters on the CT, but now it's less apparent on the EUS, so it is more collapsed. We are trying to show if we can see the layers of origin and the muscle, the sharing of the muscle muscularis propria with the duodenal wall. So we see that the cyst is collapsed. It's not very distended, so showing the layers is not very apparent. But I try to examine the duodenal wall in the same time to make sure there is no reprojection. Another way is to put a lot of water in the duodenum to increase the contrast between the mucosa and the lumen. So I will try to fill the duodenum with a little bit of water. Here I'm examining the head of the pancreas. As you can see, here is the head of the pancreas with the common bile duct, the CBD, the 2 ducts. And it's important also for the management, as we can see this lesion, to show if there is any communication between the cyst and the biliary or the pancreatic system, so that the decision can be made based upon that. So here we have the head of the pancreas, the common bile duct, the pancreatic duct. They are not dilated, there is no stones, and here is the origin of the cystic duct together and the portal vein behind. So as I'm examining the biliary system, I'm not seeing any communication with the cyst. And again, I will go a little bit deep. I will try to fill the lumen with water to increase the contrast. Any comments from the experts?
Dr. Nady?
Yes.
Please, I can't very well see very well the cyst. If you can
agree.
Show us the cyst and their relation with the pancreatitis that the patient.
The patient didn't have pancreatitis. If you can see here, very nice sign. If you can see that there is a punctum on the cyst on endoscopic view here. I will try to show. Can we switch to endoscopy, please? There is a small punctum. Do you see endoscopic now?
Yes, we can see the small
punctum
window.
Yes,
but we can see very well.
Yes,
so
I think the cyst was bigger and it evacuated with this punctum. Here, you see the flow.
You already commented it before.
I started half an hour. It was a little bit more filled with a little bit of fluid and debris, but now, as I think with the pressure of the echo endoscope, it starts to collapse. So, ممكن نحط water?
ممكن. Yeah. Well, I was suggesting for the water. If you put the water into the lumen, you fill the lumen with the water, your view is going to be much, much better.
Yes, I will start to fill the lumen a little bit with water. If you can switch also, there's a nice sign on the endosonography. If we can show the endosonography, there is...
Yeah, we are seeing the endosonography.
Yes, if you see here, there is a little bit of air inside the lesion. So maybe there is already air, and it is, as you can see, I'm trying to show, there is an air inside the lesion. Very small cyst here with air inside. It's very collapsed, but I will try to put air and see if we can fill the lumen and show the contrast between the lumen and the cyst.
Dr. Nady? Yes.
Oh, I'm sorry, Omar.
Yes,
In
please.
this type of lesions, I think the best way to do is doing the patient under orotracheal intubation to protect the airway, and do with water pump. Put a lot of water, and it's going to be very, very clear, the image.
Yes, as the patient is already intubated, we already thought of the idea of filling the lumen. So the patient is already intubated. She's in the left lateral. I didn't do it on the back. Maybe next time I will think of putting the patient on the back. Maybe it will help. But for now, as we progress with the examination, I think that the cyst empties more the fluid inside.
Yeah.
So, but for me, the punctum here. Yes, please.
Please, we have to go to Matkour for 2 minutes, and we'll come back to you,
Okay.
if you don't mind.
Yes, please.
He have some to show us.
If just I can show you the wall here, I think the cyst we can start to see that the cyst is sharing the muscularis propria with the duodenal wall. Here is the muscularis propria, and here is the start to see a little bit of fluid inside the wall here.
Yes.
Can you see it? Just before
Yes.
going. Here we have a little bit of fluid inside, and we are sharing the muscularis propria with the cyst. Is it clear for everyone, or? Here,
Yes.
a little bit of water inside the duodenal wall, and it is sharing the muscularis propria, as you can see. Here is the small cyst. It's very small. The size, I think it's inferior of 1 centimeter. I will try to measure it. But the problem that the cyst has evacuated a lot of the fluid content with time. As we have started the examination, I think it already, from the punctum, it has already evacuated its content. So the discussion will be now, if you can come back, we will start to discuss what will be the best management for this case.
Yes. Now we can go to Dr. Matkour. Dr. Amada?
Yes. Now we have the endoscopic view of the cyst, so we have tried to fix it because it's very small. As you can see, the sharing of the muscularis propria layer, and there's the small cyst, not filled with fluid, because from the punctum I think it has evacuated the fluid content. So now, if you can see on the endoscopic view, I'm just facing the polypoid projection, and as I'm pressing on the cyst, I think it's more and more evacuating the fluid. Now, I think the discussion will be about the management. So, can you see the punctum? It's very clear on the endoscopic view. Do you see the endoscopy? Please, can you switch to endoscopy?
Yeah, we can see very well.
The punctum, and there is the fluid getting out from the cystic lesion. So I think it's a very nice picture for me to see that punctum on the duplication cyst, and the management will depend first on the connection on the biliary tree. Is it connected or not, to decide? And as now we can see it very clear on the EUS. Please switch to the EUS.
Yes, you can see very clear now.
Okay,
Yeah.
so it's a small, it's not connected with the biliary tree, and it is sharing the muscle, the muscularis propria. One of the pathognomonic or diagnostic criteria is to see a peristaltic movement inside the cyst. I'm not sure, we'll try to stay a little bit if we can see any peristaltic movement inside. So the question will be, what will be the management? Would it be endoscopic deroofing, endoscopic resection, or surgical resection? I think these are the three choices that we can discuss. Can I have the opinion of the experts about? is the best.
I have another opinion. I think we don't need to do anything.
Yes, yes.
I think it's a duplication cyst.
Yes.
We thought connect to any ducts, so it's not getting obstruction of the duodenum. So it's a small duplication cyst, so I won't do anything. I won't do FNA or FNB.
Exactly.
And also, I would not resect that. I think there is no problem to have this.
Yes.
I won't do anything.
Yes, agree. The indication of intervention for duplication cyst is when it is symptomatic. For example, if it's causing valveless intussusception, bleeding, or persistent abdominal pain. But in such a small cyst, I think, and as we have proved the punctum and that is evacuating already and getting smaller with time, I think the best the best strategy will be to follow up the patient first for symptoms and do imaging. There's no clear guidelines about the best scheme of follow-up, but I think that annual CT or MRI will be enough till the cyst disappear or the symptoms improves.
So, Dr. Nady, maybe we have to reconsult again for searching for the cause of the pain. Maybe this is not the cause of the pain.
It's very small, but I don't know if the cyst was bigger in size before. Maybe it caused, and there is always the risk of infection for duplication cysts. So maybe it was bigger and it was drained with time. So the best thing I think is to follow the patient and to do imaging in 6 months, just first time, and then annual endoscopy. And annual imaging, so either MRI or CT.
Thank you, Dr. Nady and Dr. Nada, for their